Hello everyone, and welcome to the Yale20 episode on community-acquired pneumonia. My name's Brian Brown. I'm a second year in the internal medicine primary care program, joined by Sarita Soares, assistant professor of medicine in the Department of General Internal Medicine and assistant program director of ambulatory education. Let's see what we'll talk about today. So for our overview, first we have our 5-minute assessment, and so we're going to find out what things do I need to know for my patient? How do I triage the patient? And are there any relevant clinical scores that can help us out? Then we'll go on to diagnosis, and we'll figure out how confident are we even that this is bacterial pneumonia? And then, how does the chest x-ray help? And finally, what pathogens in particular do I suspect? Then we'll move on to treatment and talk about antibiotics, whether they be the empiric regimens we start right away or what we narrow down to later on based on our targeted organisms. And we'll talk about any treatments besides antibiotics as well. Can't forget those. Finally, we'll do an assessment and plan where we kind of wrap up and tie the whole thing together.
So what are the clinical features of pneumonia? There's, of course, cough, dyspnea or shortness of breath, pleuritic chest pain, which about 30% of patients might have. Chills are found in 40 to 50%, with 15% having rigors, and fever is found in 80%.
Do you know in what situations fever is less likely to be present? First of all, if you're seeing the patient in the morning time, and second, if the patient is older. Those are both reasons that a high fever response may not be mounted.
Now let's go to the physical examination. First, we're just listening to the breath sounds. What are some of the things you can hear? Well, first of all, there's crackles caused by the snapping open and closed of mucus-filled alveoli, and that has a decent positive and negative likelihood ratio profile. Then there's diminished breath sounds, which are useful if present in a certain region of the lung fields. And then there's bronchial breath sounds, which, as you note there, actually have a very good positive likelihood ratio. Then we move on to things other than just pure listening to breath sounds on auscultation. So it's believed that 1/3 of patients will have some sort of consolidation signs. And this might include egophony, represented here. Could also represent dullness to percussion. And with all of these, the concept is the same, that you have a solid area compared to a less dense area of the rest of the healthy lung, and so sound will be conducted differently through that area. What if you find none of the above on physical exam? Well, according to the Rational Clinical Exam Guide, the absence of any chest findings, such as those mentioned above, gives a negative likelihood ratio of 0.57. And similarly, how likely is it to still be pneumonia if you don't have any abnormal vital signs? That means the patient has normal respiratory rate, normal heart rate, and no fever. Well, this gives a negative likelihood ratio of 0.18, so that's very useful. So another potentially useful piece of information when thinking about your pneumonia is the quality of the sputum.
So when we think from a basic science standpoint, your typical bacterial infection is going to be attacked by those phagocytic neutrophils using all those different weapons they have. And classically, atypical bacteria that are going intracellularly and behave differently, as well as viral infections, are going to trigger this other type of T cell response. So you would think that this might lead to more of a scant or watery sputum, especially at first with the viral and atypical infections. That said, though, eventually the neutrophils are going to come and kind of act like garbage men and clean up the junk regardless. And that might explain why it's not really useful diagnostically, according to the literature, to look at purulent sputum as an indicator of bacterial over viral infection.
Now, there are some specific classic examples of quality of sputum, but these are kind of rare and definitely not very sensitive. So they're nice to be aware of, but probably not good enough to hang your hat on. And those that I'll mention are strep pneumo, is known to create rust-colored sputum, classically, and Klebsiella classically has a currant jelly sputum. So what about using clinical scoring systems to help us out? Well, the most useful one is probably the CURB-65 score. CURB-65 stands for C, confusion of new onset, U for urea, as in the blood urea nitrogen is elevated, R for respiratory rate of 30 breaths per minute or greater, B for blood pressure less than 90 systolic or a diastolic blood pressure less than 60, and 65 for age 65 or older. And the idea of this scoring system is that you can use it to triage who needs to be in the hospital, who needs the ICU, who can be an outpatient, and so on. So, if your score is 0 or 1, you have about a 1.5% mortality risk from this pneumonia, and that can be handled in outpatient care. For a score of 2, you have a 9.2% mortality. A score of 3 or higher gives you a 22% mortality risk, and so inpatient admission is recommended, and you should consider the ICU. The last thing that should be mentioned about the CURB 65 score is that some have argued that you can even do a CURB 65 score, as in without the U for BUN. The nice thing about this is that the BUN, or U in CURB, is the only part that you need a blood test for. Everything else you can do right away with physical exam and vitals. Another scoring system to be aware of is the PSI, or port score. This one's a little older, but the problem with it is it uses a lot more variables, so it's based on age, comorbid diseases, abnormal physical findings, and abnormal lab tests. In comparison to the PSI, or port score, the CURB 65 score offers equal sensitivity of mortality prediction due to community-acquired pneumonia. Notably, CURB 65 has a higher specificity at 74% than PSI, 52%. However, CURB 65 does have a lower sensitivity than PSI in predicting an ICU admission. So, good to just be aware that both exist. I'm not going to go through every variable for the PSI or port score, but you can basically look it up on MedCalc or anything else online and punch those numbers in.